Bonjour tout le monde. Good morning, everyone. My name is Antoine Baillargeon, and I'm the program coordinator here at the Ottawa branch of the National Association of Federal Retirees. So to begin, I'd like to acknowledge that the land on which the Ottawa branch office is located is traditional unceded territory of the Algonquin Anishinaabe people. So on behalf of the branch, I'm pleased to welcome you to today's session, which is titled Subjective Cognitive Decline, Multitasking, and Brain Activity. What have we learned? So we welcome our two presenters, Talia Salzman and Sarah Fraser from the University of Ottawa. NAFR members like you and many others volunteered and helped Talia and Sarah conduct many research studies, and now we're happy to have them both here to give us a look at what they've learned throughout their research. Veuillez noter que le webinaire sera présenté en anglais, mais la participation bilingue est toujours encouragée. I also want to give a special welcome here to anyone who is not yet a member of the association. We hope that these webinars will inspire you to join us. And to our members, we hope that these webinars encourage you to maintain your membership. Finally, if you have any questions throughout the session, please type them in the Q&A box, and the presenters, Talia and Sarah, will answer your questions at the end of the presentation. That's all for me right now, so I'm going to turn over the presentation. Thank you, everyone.
Thank you, Antoine. Okay, I'm just going to make sure I'm sharing properly. Pardon me, as I swap presenter view. Voila. So welcome, everybody. To start, thank you, Antoine and Linda, for inviting us back. Happy to be here today to tell you a little bit about our progression in the work that we've been doing on subjective cognitive decline and multitasking and brain activity. I'm an associate professor at University of Ottawa, and Talia is a PhD candidate in the School of Human Kinetics. So to start, I have to say it takes a team. And as Antoine said, ça prend une équipe. This presentation is in English, but both Talia and I are bilingual. So if you have questions, si vous avez des questions à la fin, en français, aucun problème. Our team, if you look at the left of the screen, there's some collaborators that we work with, Dr. Shanna Kuse and Dr. Vanessa Towler from University of Ottawa, but the psychology department, they are assisting us with the neuroscience end of things. And Dr. Diana Tabon Bayaro is from Colombia, and she's an engineer that has helped us analyze the neuroimaging data. On the right of the screen, you see a whole bunch of students. These are all people you've helped by participating in our studies. A majority of them have done an honors thesis in my lab on some of the work. And in the middle with the purple background, that's Kaya. She's doing her master's on this. She also did her honors on this. So thank you from them, because you've allowed them to work with people and have some story to tell in terms of research. Also, as Antoine said, thank you to all the volunteers. Merci pour les bénévoles. Many of the participants in the studies that we're talking about today are from your group. So I very much appreciate the support that NAFR has given to these studies. I always tell people why I care. In preparing this presentation, I realized, oh my God, I've been doing this for 20 years. I started doing work in walking and talking, multitasking, a long time ago because of my grandmother. So on the left of the screen, you see my grandmother. In her late 70s, she had a fall, and she had it while she was talking and walking rapidly. And for her, that was sort of a pivot point in her life. And she continued to have health problems and eventually was diagnosed with dementia. So that's sort of where my interest stems in all these things: brain activity, multitasking, and subjective cognitive decline. I'm even more interested in it because I lived through it with my dad, who also had a fall, and who also was diagnosed with dementia and just passed away this summer. So um, I'm concerned for people facing the condition, falls. Everyone has different trajectories, but I'm interested in how can we alter that trajectory. So is there a way that we can capture early? Maybe for me, as you see on the right of the screen, who's already got a knee injury and issues going on mobility-wise, can we identify early what's going on and maybe change some people's trajectories? Because there is research that has demonstrated that certain modifiable risk factors can alter your cognitive trajectory and help you maintain your memory, your cognition, your divided attention abilities. So just to sort of set the stage a little bit, here I'm just talking about cognitive decline and the risk factors that are modifiable. On the top, obviously in the negative color of red are things that increase your risk. And in green on the bottom are things that decrease your risk in cognitive decline. But what's important about this slide also is at the bottom, there's a little key. And you can see that the things that have strong evidence, so risk factors that have strong evidence, are actually in blue. So things like having traumatic brain injury, multiple traumatic brain injuries increases your risk of cognitive decline. Obesity in middle life, hypertension, smoking, and diabetes are all things that there's a lot of evidence that supports that these are modifiable risk factors that increase your risk. Things that decrease your risk, many years of formal education. I can go back to my dad and give him as an example. He actually had a very short period of his life with dementia, and part of that is because of his high level of education. He was a professor at McGill in engineering, and the level of education that he had helped stave off some of the declines associated with dementia for a longer period. And this is seen in other people as well. Education seems to sort of shift the window so that you maintain your cognition longer and then only have a decline towards the end of your life. Physical activity as well has demonstrated. Physical activity, as everyone knows in the room, is good for everything. It's definitely good for a preventative measure for cognitive decline. In red, we have some things that show moderate evidence. So the Mediterranean diet shows moderate evidence of decreasing your risk of cognitive decline. And cognitive training, there is moderate evidence as well that if you're doing some kind of cognitive training, usually it's on a computer, doing some games, cognitive games, this can decrease the risk. The other things that you see sort of on the right side here have a lower level of evidence. People are still working on this to support that these things either increase or decrease the risk of cognitive decline. But there's not enough evidence now to say that there's strong evidence that these will increase or decrease the risk. If you were at our previous presentation, you would have seen this graphic, and this is where some of those modifiable risk factors I talked to you about can help people maintain their cognitive function over time. So what you see here is time on the x-axis and cognitive function on the y-axis. And at the top, you see normal aging. To tell everyone in the room, it's normal to have changes, right? So it's normal to forget your keys sometimes. It's normal to come downstairs and go, what was I coming here for again? That's all a part of normal aging. There will be some cognitive changes with age. When it gets to the point of what we see in blue here, SCD, we call it, subjective cognitive decline, these are some people who feel like something's changed in terms of their cognition. Something's changed in terms of their memory or in terms of their ability to organize their thoughts or plan something. But these are really just people self-reporting that they think something has changed. In reality, these people are on the same sort of trajectory of normal aging, because when we do paper and pencil tests, neuropsychological tests, there is no difference between people who are normally aging and people who report SCD. However, there is some evidence that a portion of these people may actually be right. You know yourself, you feel a subtle change. Some of those people will be correct, and there is a subtle change. And so subjective cognitive decline might actually be a marker for those people of future cognitive declines. And when we're talking about future cognitive declines, it becomes an objective decline. So we have some evidence that supports a cognitive decline when you get to mild cognitive impairment, or MCI. This is a turning point where there are a portion of people who have mild cognitive impairment who will progress to some form of dementia. There are some who won't as well, so keep this in mind. Even if you have a diagnosis of MCI, it does not mean necessarily that you will transition to a form of dementia. And then here, once you have dementia, for sure, there's usually some pathology in the brain, and you are on unfortunately on a cognitive decline trajectory, where it'll be mild, moderate, and severe until your death, basically. So what we're talking about today, really what I want to focus on, is subjective cognitive decline. One of the reasons we're targeting this area is because we think there might be some people that are right, that have noticed some change. And maybe for those people, we can intervene earlier and change some of those modifiable risk factors and keep people on a normal aging trajectory. One of the ways that I've been doing this in the lab forever is looking at multitasking. So pairing a cognitive task, so something like a memory task or reporting something out loud, and pairing it with something motor. So walking, finger tapping, climbing upstairs. These are things that we get people to do in terms of multitasking, or the other term is dual task. Why this? There's some evidence that it's a good marker. I've used it to show differences between older adults and younger adults. So looking at how people maintain their abilities to multitask at the same time, and what do they need to do to maintain that ability. There is also evidence, as you can see on this slide, that it can discriminate between older adults who report subjective cognitive decline and older adults who do not report subjective cognitive decline. So some of the studies that have been done so far are mostly performance-based. So looking at how fast somebody walks, how accurate somebody is on the cognitive task, how quickly they respond. We've tried to go one step further, and that's what we'll talk to you about today, and look at brain activity. But before we got to that stage, we had to know we were going down the right path. So some of our very early work on this, some pilot data, was actually to ask people if they felt they had subjective cognitive decline, with a common question, with a yes or no answer. Do you feel there's a change, and do you feel you're concerned about this change? We get a yes or no answer. You are put into the category of reporting subjective cognitive decline or not. But then we have this validated questionnaire that's called the Everyday Cognition Scale. And this allows people to report the different areas in cognition where they may feel there's been some changes. So in our pilot data, if we look at the Everyday Cognition Scale, we could see that people were reporting, and higher is worse in this case. So if you're looking at this graphic, people were reporting worse memory if they had SCD, worse language skills, and worse divided attention. And I want to draw your attention to the divided attention, so because this gives us a little piece where we're saying, okay, we're going down the right path. We're looking at people's abilities of divided attention. This probably challenges people enough to be able to see differences. And importantly, just to bring this on this slide as well, we did give everybody the Montreal Cognitive Assessment, or MOCA, as you see on the screen. And this is just a global assessment of cognition. And if you have 26 or above, you are considered normal aging with normal cognition. And as you can see on the screen here, our two groups weren't different. So despite reporting subjective cognitive decline on a neuropsychological test that should identify differences, there is no differences. So we have to look somewhere else for these differences than in these standardized tests. We decided to add looking at the brain. So having people multitask and look at what their brain activity is like when they're multitasking. If you've come to the lab, you'll know that we use a couple of different techniques. Initially, most of the work is done with what's on the left of the screen, functional near infrared spectroscopy, or because it's a mouthful, just plain FNIRS. This is a band that's put on your prefrontal cortex, and we're measuring cerebral oxygenation. So basically, when you do a task and there are some cognitive demands, there's blood flow to the prefrontal cortex, and we're able to capture differences in this blood flow when the task is more difficult, like a dual task. Similarly, electroencephalogy, EEG on the right here. This is in collaboration with my colleagues in psychology. This is their CAP. Here we're able to look at the entire cortex, and now we're looking at electrical changes in the brain. So the same idea, except now we're looking at spikes in the electrical activity when you are doing a task that's demanding. We like these two. We're hoping we're going to get complementary information because we can have some information on blood flow of the prefrontal cortex, but we can also have something on electrical activity in the entire cortex. So we'll be able to look at the frontal activity as well as motor activity that could be involved in some of the tasks that we do. What are we looking for in the brain? There's been a lot of work comparing younger and older adults when they're doing multitasking. And what we see is when there's cognitive demands, as you see on the screen here, that red line, older adults tend to increase their brain activity to meet the demands. That's the blue line, the neural compensation. And so what we see when we compare younger and older adults is younger adults aren't activating their brain as much as older adults. Older adults are activating a little bit more, but they're both performing the same. So they're both able to manage the dual tasks, but the older adults are increasing their brain activity to do that. So our thought was maybe we can see this difference also between older adults with and without subjective cognitive decline, with our expectation that maybe those with subjective cognitive decline who could be at greater risk will be actually ramping up their brain activity more than an older adult who is normal aging. So to set the stage for Talia telling you a little bit about what we've learned, we've gone down this path. So far, the evidence is pointing us that divided attention might be a good way to go to look at this. It may be able to objectify people who really are at risk that are in the subjective cognitive decline category, because the current tests that we have in terms of paper and pencil tests, these people do not look different. If we are able to identify this, we can have early detection. We know from the modifiable risk factors, there are treatment options that could reverse or delay cognitive decline. This will ideally, from what I've heard from older adults, people want to age in place They want to maintain as much as possible their functional independence. These kind of things and preventing cognitive declines can help with that. And my own interest in maintaining safety and preventing falls, as I know falls are a very important change in trajectory for some people who are older adults. In addition, identifying this might actually give us a pinpoint of who in these people that are reporting subjective cognitive decline are really the ones who are at greater risk of further cognitive declines like mild cognitive impairment and dementia. And again, ideally intervene before there's significant pathology in the brain. So that is where I will stop talking and I will give the floor to Talia, who, by the way, has done all this work. So kudos to Talia, and she'll tell you about the studies that you have participated in.
So hi, everyone. As Sarah mentioned, my name's Talia. I'm a PhD candidate at the University of Ottawa in human kinetics. So Sarah has done a really good job at giving you guys some of the background and theory about why we're thinking the way we are, why we're doing what we're doing. So as Antoine mentioned earlier, we came a couple years ago to present some of our ideas at that time, which now I would say have resulted in some actual experiments, some results. So I definitely like to go over some of that today. We've had, as everyone has mentioned, we've had a lot of people from this organization participate in this study. So it kind of gives you an idea of the lag between when you actually participate until when we get published results. It's about a year. So we'll go back to 2021 when we first started this idea. So in 2021, sorry, if you go to the next, our initial idea was to, or sorry, you want to press next on the slide? Yeah, so we began with a pilot study. So essentially what this is kind of like a proof of concept to see whether or not we can actually do what we're reading about in the literature, implement the theory. So we did this on a small scale. So first looking at the task. So what kind of multitask should we use? There's obviously two components to the multitask. So what kind of motor thing do we want to have people do? Or what kind of cognitive thing do we want to have people do? And then in addition to that, Sarah, if you could go to the next one, we're looking at neuroimaging. So as we discussed earlier, so using functional near infrared spectroscopy. So FNIRS, whether this even works. Subjective cognitive decline arguably is something that's very subtle change. So if we're not seeing differences on paper and pencil tests, learning whether or not we can see whether there are differences in the brain. So again, this is a very new area of research. So really starting from the beginning and testing to see whether or not we could detect differences between people. So then in 2022, we based on the results, so I'll discuss it a little bit more in the coming slides, but just to give you an idea, the goal for our next study was based on the results that we found from the pilot study was to increase the scale. So increase our sample size, hopefully get a more diverse sample as well. And we learned mostly what we focused on is manipulating only one component of the multitask. So looking at the motor aspects, and just briefly, the reason for that being that we do, not we, but in the literature, there is a relationship between cognitive decline and motor abilities. So we found some things about finger tapping, as I mentioned, which I'll talk a little bit about soon. And then as well that we were able to use FNIRS to do this. So increasing the scale to be able to do that. And now more recently in 2023, now 2024. So these are kind of ongoing studies that we have as opposed to the previous two, which we have some results for already, is to refine and replicate what we've learned. So we still are learning things from the previous studies. So updating those things, fixing the small things, and again, being able to replicate it. So that's really important to be able to not have things, I guess, occur by random chance. So if you could press the next button. So firstly, looking at literature updates. So as I mentioned, this is a fairly new area of research. So what has been published, what are other people doing since we started this in 2021, and as well to see if people are getting the same sorts of results that we're getting. And then as well, looking at the tasks. So at the beginning, we were focusing on looking at the motor components. So we looked at walking, we looked at finger tapping. But now looking at the cognitive component, because ultimately subjective cognitive decline, it's in the name. What's the difference if we use different types of memory tasks, for example? And then lastly, using a different type of imaging. So while we see this works with FNIRS, there are strengths and limitations for that device as well as other ones. So seeing whether or not we can replicate this using a different device, which is measuring different things and can also measure the whole brain. And then lastly, thinking into the future, looking at interventions. So it's great that we're getting all these findings, but then how does this then apply? Is there anything you can do about it? There's also the perspective of ethically, let's say you find something about someone, but then there's no cure for it or no treatment. What's the point of doing it? So looking at interventions, we have a pretty large study that we're doing right now on that and whether or not it can actually help to improve your cognition. So what components can we include in intervention, going back to what Sarah was saying about modifiable risk factors and whether or not we can include this in an intervention that people can implement into their everyday lives. So if we go to the next slide. So beginning again back in 2021, when we started our pilot study, we were looking at different types of multitasks, specifically focusing on the motor component, seeing whether or not we can determine or find differences in brain activity when people are multitasking by either typing on a keyboard and doing a memory task or walking. So that's what you see in the pictures on the right. This was back still during COVID when we were wearing masks. So our participant here is wearing a mask as they're participating in our study. And then another question we were asking is whether we can use neuroimaging to be able to detect differences between people. We started, as I mentioned, with a very small sample size, so 20 people, 10 in each group, with subjective cognitive decline and without. And as well, Sarah mentioned this briefly, the way we determined these groups mainly was using a single question. And this is kind of what's been done in the past is to ask a single question. We evolved that question a little bit in terms of just asking, are you concerned about declines in your memory, attention, or language abilities? Again, going back to that table that we saw earlier, memory, attention, and language ability seem to be what people are most reporting. So memory could be things for like your short-term memory, not remembering things as well as you used to. Attention, your attention capacity, maybe you're not able to maintain your attention or divide your attention in a way that you used to be able, and language abilities. So sometimes forgetting words when you're speaking, or like you see an object, you know what it's called, the words on the tip of your tongue, but you can't necessarily spit it out. So if we go to the next slide, just to discuss a little bit about the results from this. So what we found is, and if you go to the next again, is this was recently published from our lab back in October. So if you're interested, you can have a further look into this. But the main thing, what we found is greater brain activity in the group with subjective cognitive decline compared to the group without. And that's specifically when we did the finger tapping dual tasks. So not during the walking, when people were sitting, typing on a computer and doing a memory task. So that's what you see in the bar graph on the right. The red bar, you could see it is the SCD group, and you could see that they're activating their brain a lot more than the group that doesn't have SCD, which is like the black bar to the right of it. And this goes back, if you go to the next button, you could see that what we found as well was that in terms of objective cognitive performance, so performance on an actual paper and pencil test, the test that we discussed earlier, the MOCA, that helps to predict, or not predict, but show risk of future cognitive decline. Both groups, the SCD and non-SCD group, SCD in red in this figure, they both performed similarly on that test. But then what we see in terms of your brain activity, if you press next again, it's back to the idea of maybe compensation, that one group is increasing their brain activity more or putting more mental effort to achieve the same level of results or performance as the non-SCD group. So now going to the next slide. So this is the study that came after that. So from what we learned from that study, we decided to modify some things, improve some things, and mostly as well to increase the scale. So we doubled the amounts of participants that we looked at. So we looked at 40 people, so 20 people in the SCD group, 20 people in the non-SCD group, we moved forward with our neuroimaging idea. So this was still using FNIRS because we did find some differences, as we saw on the previous slide, between both groups. And then compared to the previous study, now we're also interested in looking at the cognitive component of the multitask. So we determined that we found things when people were typing on the keyboard, but what about when they're doing the memory task? So before I spoke about the memory task and on a general level, but essentially we looked at two different things. So with the picture you see on the left with the number 1, so that's what we call our N-back task. So N stands for, it could be any number. We were specifically looking at a 2-back. So what this means is that participants, or what you could see in the picture on the right, he's wearing headphones. And that's because he's hearing a sequence of numbers appear, not appear, but he hears the sequence of numbers. And for example, if it's 4, 2, 7, when he hears the 7, he has to say the number 4 out loud. When he hears the number 4, he has to say the number 2 out loud. So this is what we call a working memory test. So it's your ability to maintain things in your short-term memory. So remembering these new numbers that keep appearing, but then also being able to manipulate that information. So being able to remember the number and then immediately, I guess, throw it away from your mind because you have a new number coming in and a new number that you have to answer to. So people were sitting in front of a computer, as you could see in the picture. They were typing on the keyboard while saying these different numbers out loud. And then a second thing we did, so another working memory task, but this one was different in the sense that it was visual. So the participant would see a number appear on the screen. So this is a what we call the double number sequence task. So people see a 3-digit number on the screen, and then we give them 2 different what we call target numbers that they have to count amongst the sequence of 3-digit numbers. So for example, let's say you have to count the numbers 4s and 2s. If they saw the number 462 on the screen, they would have to count, say they counted 1, 4 and 1, 2, etc. So again, you could see how you would have to constantly be tallying numbers, manipulating information in your mind. And we always tell people you can't use your hands, you have to do this in your head, you can't speak when you do this. So that's what we asked them to do for that task. And now in terms of results that we got from this study, so so if we go to the next slide here. So we found, again, similar to in the previous study, we found greater brain activity during the dual task. So this was specifically during the multitasking condition, that the SCD group in the red bar on the figure on the right, showing that, again, there was greater brain activity in the group with subjective cognitive decline compared to the group who doesn't have subjective cognitive decline. And again, that's from asking the question, are you concerned about your memory, thinking, and language abilities? And we see that performance, again, between when you do the paper and pencil tests, they're similar between both groups. And as well, I should mention, if you go press next again, this was during the double number sequence task. So we didn't quite see this with the N-back, but doing the target numbers, the visual task, that's when we saw differences between people. So now if we go to the next slide. So now this is more, I guess, current in the sense that we don't have complete or published results on these next 3 studies yet, but it's what we're doing right now. Some of the studies are still ongoing. So for example, starting with this one is the literature review. So now that we found those different things, if we go back into the literature, can we see what other people have done? Are they finding similar things to what we've had? But another important thing that we are looking forward to, and it's also really important to consider. So if we think of cognitive decline kind of on a continuum, which is what you see in the red arrows at the bottom. So if we think of non-SCD, we call non-SCD controls, people who don't think they have or have noticed any changes in their memory is as good as it's ever been, then followed by people with subjective cognitive decline, and then mild cognitive impairment and dementia. So these are objective stages on cognitive decline where people would perform differently, say on a paper and pencil test, in addition to other factors, of course. But it was important for us in this literature review, something that we haven't examined yet, but comparing SCD to then the objective stages of cognitive decline. So what are we seeing in the literature about that? So we found that dual task performance, so doing the multitask, was worse than single task. performance in SCD. So that's exactly or similar to what we saw. But then in addition to that, when we compare SCD to mild cognitive impairment, something that we haven't done, but something that we see in the literature, is that we see walking speed is slower in the mild cognitive impairment group compared to subjective cognitive decline. So that's what you see in the figure. If you look to the right of the 0, you could see all the data favoring, in terms of walking speed, the subjective cognitive decline group compared to the mild cognitive impairment group. What we also found is that there wasn't enough data on neuroimaging, so not a lot of people are doing multitasking with neuroimaging for us to conclude anything like this, that other people are finding the same things as us. It is a new area of research, but we can't conclude anything from our literature review as to what type of imaging to use or what region of the brain to look at. So I'll talk about that a little bit more later when we decided to go ahead and use a different type of neuroimaging. So if we go to the next slide. So beginning with the idea of changing the task. So what we saw in the literature review is that with SCD compared to the next stage of cognitive decline, again, it doesn't necessarily mean if you have subjective cognitive decline, you will progress to mild cognitive impairment. But seeing as we saw that there's a difference in walking, whereas we didn't see that, maybe it's about making the motor or the walking component more challenging. So there's like a fine line between having someone do something so difficult that really what we're measuring is their stress level, or it'll be just unpleasant to do and they won't try to do it, as opposed to finding something of the appropriate difficulty that's difficult enough to cause you to activate your brain. So what we did is a similar study to what we've been doing previously with our memory task, but rather than walking on level ground, we had people walk on a flight of 4 stairs. So again, we did this at the same time. So they would hear the memory task, they would walk. And just to give you a little preview before we go to the next slide, I'm comparing it with EEG. So I'll talk a little bit about that on the next slide, but there's pros and cons to using different types of neuroimaging. So beginning with user training. So a lot of the students in our lab have done this type of data collection. So just realistically, in terms of training people, having people learn how to use this, it's quite minimal training to use the FNIRS device compared to EEG. There's a lot more setup involved, and in the analysis, it's a little more complicated. A big one for us is motion tolerance and portability. So we do a lot of studies with walking. So it's important, as you could see, like the participant wearing the headband on their head, and our device works with Bluetooth, so they can walk around with it. People have done studies with this device, different exercise studies. So it's quite portable compared to EEG, which is, you have to be quite stationary. It's as sensitive as measuring things like you're blinking. So those are things that we have to then incorporate into our analysis later on. And lastly is the comfort. Whoever is going to be using this has to be comfortable wearing it. So the FNIRS is like a headband that you would wear. It's silent. Both of them are non-invasive. EEG, on the other hand, though, because it's measuring electrical activity in your brain, as opposed to FNIRS, which measures oxygen levels in your brain, we have to use gel in order to be able to get a clear signal. So now if we go to the next slide, our third study here is when we used our second type of imaging, is what you see in the picture here. So EEG stands for electroencephalography. So again, the participant has to be quite stationary. So we did the computer task, the double number sequence task, where they're typing on the keyboard while counting different numbers. And some advantages of EEG are the cost. Arguably, it looks the same as FNIRS, but nonetheless, they're pretty expensive, relatively speaking, technologies to use. And then 2 other things that are important to us are the sampling rates and the temporal resolution. And what this means is, compared to the FNIRS device, we're able to get a lot more data points in the same amount of time. So this could translate to, for example, not having the person have to repeat the same task over and over or count so many numbers, because we can get more data points, but also the timing of it. So looking at electrical activity in the brain, the timing of when you activate your brain is also important. So there's like learning effects, practice effects that come along with that. So the more times you have someone do something, the better they're going to become at it. So that's why that's important. And then lastly, I touched on it a bit, the temporal resolution. So relating to time, this is on like a millisecond level. That's how fast we're able, I guess, to acquire the data relative to when you responded to whatever task we're asking you to do. And so we didn't have results for those past two studies, but the significance or hoping of what we're doing is to look at a novel approach of something new, like a multitask, to be able to identify changes in brain activity. So multitask are things that we encounter in everyday life. And there's also the aspect that looking at your brain is not directly observable compared to when you do a paper and pencil test. So kind of going a step backwards and looking at what is causing you to perform in the way that you are, and that maybe there are changes that occur before you even see changes on a paper and pencil test, for example. And that goes into the idea of compensation. So increasing your brain activity to perform at the same level as, say, someone else. And then future studies, it's important. So what you may have noticed from these studies, we measure these or we collect this data a lot in like a 1 or 2 session intervals. So it's important to look at this long term to see, is this something we can track, or is it something that we should track maybe over a year, maybe over a few years, to see how people's brain activity changes. And again, the goal of this is to use this potentially in addition to existing methods. So it's very preliminary what we're looking at. So we can't say, for example, that this on its own, your multitasking ability, your brain activity, will be able to tell anything, but hopefully using it in addition to other things can help give more information about your cognition. And then lastly, the hope is to provide a better understanding. If you can go to the back, yeah, if you can provide a better understanding of interventions, and that's what I'll talk about in the next slide, that can help to improve brain health. So what types of things can we do to and modify in your day-to-day life to help improve your brain functioning? So if we go to the next slide now, this is, I'll talk a little bit about interventions. So this is something we have actually going on right now. The website link is at the bottom of the slide there if you want to check it out. So we're looking at people, specifically if you're feeling forgetful, or if you've noticed maybe your memory isn't as good as it used to be, forgetting words when you're speaking. It's a Canada-wide study that we're doing. So very interesting that we're able to reach a lot of different people. So 8 other universities across Canada are looking at the same things as we are, which is at interventions that can help improve brain health. What you can see now in these different publications, this is what's come out so far from the earlier phases of this studies. So first looking at whether or not there are factors that you can incorporate into your life that can help to improve your cognition, but then a study that came directly from our lab as well, showing that on top of, for example, a factor like physical activity being beneficial for your brain, what are the benefits of combining multiple things? So what if you were physically active and you had a good diet? So interesting part about this study is it takes place entirely online. So from your home, you could realistically do these interventions from anywhere. And ultimately, these are interventions that we're hoping can help to improve your brain health. So if you go to the next slide, these are just some of the components of the intervention. So we're looking to compare 2 different groups. So firstly, our intervention group, and this involves biweekly coaching. So every 2 weeks, you would meet with someone from our research team, and they help design or tailor an intervention to you. So for example, physical activity, this will change progressively throughout the year of the study, but also tailored to your current abilities. At the same time, you'll be doing cognitive training that will take place a couple of times a week for 20 to 30 minutes, as well as getting advice about your diet and sleep habits. And lastly, vascular risk control. So that let's say you have high blood pressure, how to manage that. Then we're comparing this to a second group, which is what we call our educational program. So rather than having a biweekly coach lead you through this, it'll be self-directed. So we'll send you a couple of or a few chapters to read every week. So it's about 40 minutes per week of your time where you would learn about physical activity, cognitive training, diet, sleep, and vascular risk control, in addition to the benefits of social engagement. So interacting with other people, going out and doing different things. So if we go to the next slide, if you're interested in participating in any of our studies, including the ones that I just described, generally who we're looking for people over the age of 60. If you're feeling forgetful, if you're not feeling forgetful, we're looking for people who have good self-reported health, meaning haven't been already diagnosed with Parkinson's or Alzheimer's, who don't have any hearing or vision impairments, meaning corrected vision, for example, is fine, like if you wear glasses. and also that you speak English, because a lot of the tests that we administer are only validated in English. The time commitment varies between all our different studies. Sometimes there are a couple of sessions in person at the university. Other times, for example, the study at home, this one takes 12 months to complete, but your commitment on a weekly basis ranges from 40 minutes to 2 hours per week. So if we go to the next slide. So thank you so much again for attending the seminar today, and for everyone who's participated in our studies. Our contact information is here on the slide. If you're interested in learning more about these studies or participating in them, feel free to reach out to us. And now as well, we'd be happy to take any questions.
Perfect. So we do have some questions in the Q&A box. So I can read them out to you too. And then, if it's answerable, just, let me know. So 1 second. Okay, so our first question, I think, goes back to one of the earlier slides. What is considered moderate alcohol consumption? I think that was one of the things leading to less cognitive decline, if I remember.
It's different for men and women. They've actually lowered it recently, so that it's 2 glasses a week for women, and I believe it's 3 or 4 for men. Don't quote me on that though, but they just changed it recently to lower the amount.
Okay. Our next question is, what is the difference between dementia and Alzheimer's diseases?
I can answer this one. So dementia is more of the umbrella term, the broad term for the neurocognitive disease of people having worse memory, whereas Alzheimer's is a specific type of dementia. There are many different types of dementia, like Parkinsonian dementia, frontal temporal dementia, Lewy body dementia. There's a bunch of different types, with Alzheimer's being one of the more prevalent ones and the ones that we know a lot about.
This person is asking a bit of a general question. Will the lack of memorization in our education system, such as the lack of music programs, memorization of poetry, and dependence on technology for retention of information, contribute to cognitive impairment in late life? So, bit of a loaded question, but if you have any insights.
That is a great question. We will have to look at that. That's something we will have to study more. I can tell you that when I did my PhD, I had people do a math task as a dual task, and I compared younger and older adults, and the older adults did better than the younger adults because they were used to doing math in their head.
Right.
So I think there probably is an advantage to some of the ways that we learn things earlier in life and the way it's moving towards more technology now. But I don't know. I mean, there's other people that would argue that the technology frees up the brain to do other things, so could be beneficial, but I'm not sure. I think we need more research on that.
And I'd also just like to add to that as well. So firstly, I'll say that you might have, if you remember her picture from the beginning of the presentation, the master's student in our lab is looking at specific factors like that. We call them cognitive reserve factors. So factors from earlier in life that can actually help you preserve your cognition later in life. One of them being your education level. So it could be that memorization can help you later in life, but I wanted to add as well, anecdotally, something that I observed, something that a participant has told me. There's a lot of other ways that memorization, for example, is incorporated into your life, even into your work life. So although it's not in your early education, for example, we had someone who's a translator do some of our tasks and did very well because they're used to doing this type of thing in their daily life. So there's aspects like that that can, I guess, make up for whatever you're missing in your memorization in school.
Interesting. This question is asking, how old is an older adult? So I think you mentioned you're looking for older adults. So what is that exact definition?
That's a great question again. In Canada, it's defined as 65 years and above. but I don't know that that's not going to shift, because the largest growing age group in older adults is 100 plus right now. So people are living a lot longer. So I'm not sure that the original definition is 65 years of age, but we start a little bit earlier in the subjective cognitive decline studies because we're trying to get people before there's any changes in their brain. So a little bit younger.
Okay. This person is asking, how did you control for pre-existing conditions in your research groups, such as mobility issues or sensory deficits?
So for example, with mobility issues in a study like stair climbing, people who have mobility limitations wouldn't be able to do that study. So that's why it was really important for us to do a second type of task like finger tapping, which would be more open for people with mobility limitations. And then the second part of your question, I think, was hearing.
Yeah, sensory and mobility issues.
Yeah, so a ton of factors like that we do incorporate into our analyses, like not necessarily if we see something, but if there's something unusual in our data, we can account for these factors because we do ask people all these questions before they come in, as well as something that we've been asked a lot when we try to publish is about cardiovascular risk factors, right, Sarah? So that's something that's been really important to us to account for in our studies. So we do ask people these questions ahead of time and then account for them in our analysis, whether it's pulling our data in one way or another, or see what the results are when you account for these things versus when you don't. And this applies to things like sex too, male and female, age, things like that. And then just not to get into the nitty gritty as well, it depends on our sample size too and how many we get of people with different types of comorbidities. So that affects it as well.
I would just add too that when we're screening them, we ask them if they would be comfortable doing stairs for X amount of time, or if there's something that would make it uncomfortable for them, and we let the person decide. We keep the information, but we let the person decide. And we have done pilot work with, for example, people with multiple sclerosis doing the stairs, but it's the people who are saying they can manage the stairs, so they participate in the study.
This person is saying, I understand the concept of the single and multitasking, but I don't really understand the NBAC or the double test. So maybe you can explain that a bit again, if that's okay.
Yeah, so starting with the NBAC task, so both these tasks are tests of your working memory. So what we're looking at is your ability to remember things in the short term and then manipulate that information. So for example, with the NBAC, we have a sequence of single-digit numbers that play at a specific interval. So for example, the numbers where you would be hearing this would be like number 1, and then 2, and then 3, etc. And as soon as you hear the number 3, you would then have to respond out loud. So we would ask you to say this out loud, the 2 numbers earlier in the sequence. So if you remember, the sequence was 1, 2, 3. When you hear the 3, you have to say the number 1 out loud. If you heard the number 4, you would say the number 2 out loud. So you're constantly saying out loud something you heard about 5 seconds earlier. And then in terms of the double number sequence task, that one is different in the sense that you, rather than hearing the numbers, you see it on a computer screen. So we give you 3-digit numbers, for example, the number 100. And then separately, we also give you 2 numbers to count. So let's say the numbers are 1 and 2. When you see the number 100, you would only count 1, 1, because, oh, the number 1, because there's only 1 in 100. And then let's say another number came out that was like 111. You would add the number of ones with the previous number. So now you would have 4 ones. And I don't even remember what number. See, my memory's bad. I don't even know how to remember it. I don't remember what number I said to count. But essentially, you're doing that over the course of the whole task. So looking at numbers, trying to count them, and then at the end, we ask you how many numbers you counted. I hope that clarifies it a little bit.
Right, so you're keeping a tally, kind of
Yeah,
a running
Exactly.
tally of how many of those digits you've seen.
Basically, we want people to be actively keeping things in mind and having
Right.
to continually respond. Kind of like if you were doing a math test and you had to continually do your 2 by 2,
Right.
2 by 3, and so
Yeah.
on. Keep having to update in your brain.
And it's also a way for us to ensure that you're like constantly engaged in the task. So if you say didn't count a number, it comes out in the end if you don't get the exact correct answer or something like that.
Right. We have a question saying, asking, can I participate in the study if I have hearing aids?
Yeah, so for example, the last study I talked about with the intervention, you can certainly participate. If you have hearing aids, we do ask a questionnaire just about your like overall hearing abilities, but that as long as you can hear us when we administer the tests, it's perfectly fine.
Okay. And for the long-term study, is it possible to participate if one is away for 1 or 2 weeks on holidays during that time?
Yeah, absolutely. So that's one of the great things about the study. As long as you have internet connection, you should be able to participate. If you had travel plans in the immediate future, you can definitely reach out to us when you're back. If you have travel plans in, say, a month, or everyone has unpredictable travel plans, the main thing is that we would send you some equipment at different parts in the study. So as long as you're at a Canadian address to receive them, it should be fine.
Okay, good to know. Oh, this person is also asking about hearing aids, so we've already answered. What are some examples of cognitive training?
Yeah,
So I think,
it's
go ahead.
it's like, or I don't know if Sarah, if you want to answer, but it's a platform that we use that you would log into for 20 minutes at a time. And I don't know, Sarah, if you want to explain it more what it is.
Yeah, so there's as part of the Canadian Consortium on Neurodegeneration in Aging, which is a mouthful, we call it the CCNA. There's a group of researchers across Canada that have created a platform called Brain Health Pro. And within that platform, there's educational modules, and there's the possibility of doing some cognitive training, which would be more like it's kind of video game like, where you will train things like multitasking. So we'll get you to, press a button because you see one thing on the screen, and then press a button with your other hand if you see something else on the screen, and then do something different when there's the two things on the screen, for example. There are packages, the other packages that have been rolled out that you can actually try online. I'm in the off the top of my head, I have Lumosity in mind, which you can try for free. And then if you want to have the full gamut of the games, then you have to pay something per month. But you can try it for free. It's an app.
Perfect. Our next like 3 questions all have basically asking how a specific aspect relates to your study on subjective cognitive decline. So this first person asking, is there an impact or is there a correlation? What is the impact of deafness on subjective cognitive decline? And if corrected, does it make a difference?
Okay, that's a great question again. I don't have a direct answer for subjective cognitive decline. I don't think we know the answer to that yet. But I do know from a large, massive research study in the United Kingdom, that people have demonstrated that if you have a hearing impairment and you correct it, then you have less chances of dementia than if you have a hearing impairment and you do not correct it.
Interesting.
Yeah, you have to think about too, like what is losing your hearing, like what kind of impact does that have in your life? Obviously, it has a ton of impact, but using an example, for example, social engagement, it might be harder to engage socially with other people. So that can be a reason why like hearing can affect other factors, I guess is what I'm trying to say. So that could be a link as to why it would be related to cognitive decline.
We have a lot of questions left. We're coming up on 11 o'clock. I think if it's okay with Sarah and Talia, we can maybe answer a few more and go a bit over time. This person is asking, does anxiety play a role in the increase in brain effort for the finger tapping tests? I recall feeling worried and really putting a lot of effort while doing that test. How do you separate anxiety from increased effort?
So that's actually something we learned between a couple of studies that we did. So now we do have an anxiety questionnaire that we ask people before to get a general sense of their anxiety. So we can account for that, like we were talking earlier about accounting for other factors that can influence our research. I suppose we can't specifically quantify in an individual what their anxiety was. But another thing we do is throughout the actual experiment, we ask them different types of questions to see how they're feeling throughout it. So we have that data as well to account for later on.
And I would add, to answer that question, we're also looking at your own performance compared to your own performance. So, and the fact that we have multiple times where we ask you to tap alone or tap with something else, we're able to sort of quantify over a bunch of trials, how are you? So if you were stressed when you were tapping alone and stressed when you were dual task tapping, hopefully across the trials, we'll be able to sort of minimize that level of stress, and the comparison should be similar between conditions. But like Talia said, if not, we can also use our anxiety measure as a covariate and just try and control for how anxiety might have influenced the results.
Yeah, so I didn't hear who asked this question, but if you did participate in our study, you probably remember us asking you to do the same thing kind of over and over. So again, it had nothing to do with how you were doing on the test, just that we needed to see how you did at the beginning, how you did at the end. So we can compare for things like learning and practicing and anxiety, things like that. So there was a reason for doing it that way.
And I think you might have already answered this, but is the study only for English speakers, or are French speakers also can participate?
Yeah, so for the last study, I talked about the 12-month study. I mean, I'm bilingual, so I could definitely do some things in French, but a lot of the tests, or for example, our consent form is only in English, so you'd have to have a level of understanding of English at least to be able to read that and understand what's required of the study. And for example, if we gave you like a test where you had to remember words, that you would be able to do that in English.
Okay.
I would add for that person, I'm very frustrated sometimes that we don't have all the equivalencies in French and English. I'm trying to make a collaboration with Montreal so that I can offer a randomized control trial that's completely in French to people who are interested in participating in French. And I don't know, I think it may be offered virtually. So if you would like to write to me and you're interested in something like that, I can point you to the person who's doing it in Montreal, and it's virtual and complètement en français. Il y a d'autres études dans notre labo qui sont bilingues, que tous les matériaux sont en anglais et français, donc n'importe qui peut participer. Mais malheureusement, le gros synergique, on n'a pas tous les matériels en français, malheureusement.
Okay. Okay, I think that's all we have time for. So if people have questions, is there an email that or somewhere they can maybe ask some further questions?
So in the slides at the end, there's our lab email, which is dtLab@uOttawa.ca.
Or maybe you could
you
write it in the chat. I can write it.
Yeah.
I'll put it in
Okay.
the follow-up email as well.
Okay.
So yeah, just so if people have further questions, feel free to email them. But it seems like that's all we have time for today. Sorry, we're running a bit late. Hopefully everyone's okay with that. So I think I'll just do a few final announcements. 1 second. Oh, there, you should be able to see me now. Okay, so just a big thank you to Talia and Sarah for their presentation today. I mean, a lot of people here clearly participated in your studies. It's been great to hear the results, and we're hoping that our branch and can still work with you in the future for future studies and maybe more of these webinars. So thank you for coming on and having this great presentation for our members. And remember, to everyone here, we hope you enjoyed the presentation. Remember that we will be sending out a follow-up email, and it will include information on how to access the recording of today's presentation if you want to go back and watch some parts of it. And we'll also include that email address to get in touch. And finally, remember that you can invite non-members to participate at these webinars. And we have a bunch of great webinars coming up in the following months to come. So if you want to see any of those, please visit our website, nafrottawa.com, and we'll be including that in the follow-up email as well. Okay, thank you, everyone.
Thank you, everyone.
Thanks, everyone.
Have a great day. Bye-bye.